My name's Richard Phillips. I'm a journalist with the World Socialist Web Site, and today I'm speaking with Dr Pippa Yeoman. Dr Yeoman is an educational ethnographer and a senior lecturer at the University of Sydney. Dr Yeoman has long COVID and is a member of the long COVID Facebook community support group. Thanks, Dr Yeoman, for your time. First of all, can you tell us a little bit about yourself, how you ended up catching COVID and then long COVID, and how you became involved in the support group?
Sure. Hello. Thanks for having me. In terms of background, I'm a university lecturer, so I'm used to, and as an ethnographer, I'm used to observing other people and what they do. And being in this space now where other people are needing to observe people with long COVID, it's quite a different space. So I exist in this space as somebody who inadvertently ended up here rather than as an object of research attention, which is kind of what I'm used to doing. So when I got COVID in early March, it was once we'd started moving back on campus. One of my sons came back with COVID and he brought it into the house, and I got one case, and then I got over that and then went back to, then we were called on campus to teach in person. Went back on campus and got a second case, and it seems 2 immunologists have told me that it was likely to have been 2 different strains. So within a month, and I think for me, the hard thing was that I'd been keeping up to date with health advice, and I'd had all my shots. So I'd had two vaccines and a booster, and I'd been doing all the isolating and everything. And then I ended up with 2 cases within a month, which was confusing because at the time, New South Wales Health advice when I phoned them was that don't worry about testing, you'll be fine. You might test positive for a long time. I ended up testing positive by a rat test for 31 days. And I ended up phoning New South Wales Health because I knew I still tested positive, but I'd passed my be in quarantine phase. So I phoned because I needed to go and see the doctor after 31 days. And the GP's first response when I said that I was still testing positive, I was masked, she was masked. I'd phoned New South Wales twice, New South Wales Health twice. They said I could go. And she stood up and asked me to leave. And I really understand the conflict. That's the person who's lived through 2 years worth of being on the front line. And her initial response was to move away from me and ask me to leave. So having done all the right things and asked all the right questions, to have that as my first interaction with a healthcare provider was quite confronting. So that went on, and then I just never got, after that second one, I never managed to teach and be on campus from that point on. I limped along, and because we were mostly at that stage allowed to opt to teach from home, I was sort of managing, but I was working really hard 7 days a week to do 5 really poor work days and just exhausting myself. And so that was March, April, and in May I came undone. There's just no way I could have carried on. And my symptoms were, right from the start, were a mixture of orthostatic intolerance, which is like I get dizzy really quickly and I can't stand up. Even now I'm sitting, my feet are up. I can't sit with my feet down for very long. And lots of dizziness and a fair bit of, people call it brain fog. I find it a very disparaging term because it just diminishes what it feels like to be able to think thoughts, but not say thoughts. So quite often you can think thoughts and you know what you want to say, but you can't put the sentences together. So you have to learn to speak differently to express yourself. And then if you put on top of that, as a lecturer, I teach in 3-hour blocks. So I've got to be able to cope with the cognitive challenges of organizing my thoughts and expressing them for 3 hours in person. Well, it was online at that stage. And then you're doing the mental toggling between all the equipment that you're using, where all the other people that you're teaching in a team with are, where all your students are. You've got video interface, you've got text interface. So it becomes quite challenging. It was too hard for me to do. The other thing is that I have although I was a mild case, I was at home and I wasn't actually that sick. And I didn't get well, but I wasn't, in my estimation, terribly sick. But I was left with, I never called it breathlessness. I always thought of it as a lack of oxygen. And I still can't, if I don't take the medicines that help, I can't talk. If I don't take the medicine, the one medicine that helps me with my breathlessness, I can only talk on the out breath. So I have to then use the cognitive challenge of organizing my thoughts and speaking on the out breath. It just makes it really, really difficult to carry on life that's a life of thoughts or a life of speaking. So it has an enormous impact on my ability to carry out my work. At least there's a fair amount of my work. And I didn't work for 5 months. So May, June, July, August, September, I was off work completely. And thankfully, I'm fully employed and I have very good benefits for which I am grateful for. I know that there are a lot of people who are not in that position, and there are a lot of casual workers who can't access those kind of benefits. So whilst I'm grateful for the benefits I have had access to, I'm very conscious that that is a big privilege. And that allowed me time to, I suppose, catch my breath. But it's really difficult to do and to disengage to do that. So that was quite a long period. I'm now trying to work 1 day a week in chunks. It's exhausting. I have a pulmonary embolism. I have, what else? I have adrenal insufficiency and all the orthostatic challenges and the brain fog. And taken together, it's not something small, and the public messaging ought to warn people that if you take risks and you get this, you've got a 5% chance of ending up with something pretty crippling, because there's no way I could function now after nearly 8 months doing my job the way I was before COVID. So it's if it is, I don't think it ought to be an individual's risk. Individuals ought not to be forced to be the responsible people making decisions. This is a population level challenge and it ought to be dealt with as such. But if we are going to be individuals responsible for making our own healthcare decisions, we ought to have good information on which to make those decisions, and we clearly do not. And part of that is that nobody talks about what it's like to have long COVID and what that means for your personal. So I've talked about economic life and my work. In terms of your personal life, you end up with a really tiny life. You can do very little in a day, and this interview and one other social interaction will be all I can manage this week. So in my downtime, I'm doing nothing that involves visual processing or social interaction. Otherwise, I can't cope. So I might be able to sit and do research-based writing and stuff for more of my time, but I can't interact. And that's a big change. So if people are to be able to make individual choices, they ought to know that. They also need to know how, if I go out somewhere, I want to know how many people are infectious out there. I don't want to, if I have to make an informed risk assessment about going out there and not getting it a third time, how do I make that decision now? And why is it not safe to go to be in public transport or be out in an education institution, or people should be wearing masks. So I think that's the thing, is that it is profound. It profoundly impacts your personal life and your working life. And if it is my responsibility then to make decisions about how I go out and how I move about, I'm not able to make those decisions in an informed way because I don't have access to information.
Well, everything you're speaking about here is at odds with the official messaging from the authorities, which is it's a personal responsibility. And as Paul Kelly said, when they announced that they were getting rid of mandated isolation, it's not really a problem, or it's not much of a problem in Australia because everyone was vaccinated. So all the things you're describing here brings you into conflict with the official messaging. Presumably, that's why the Facebook page was set up and why you're speaking to us today, to alert people to what is actually going on.
Yeah, the Facebook group was set up, I'm not sure exactly when, but it's been going for a while. It has grown hugely in the last couple of months, which refutes the statement that Omicron doesn't lead to high numbers of people with long COVID. We're in this tricky place where we've done a survey. We're at nearly 3,000 members. When I joined in May, there were barely 1,000, and we're nearly at 3,000. And most of those people have got long COVID from the Omicron wave. So the Facebook group is taking the opportunity to speak. It was set up to get groups of people together. In the absence of anything else, we could share experience and share knowledge. And it works very effectively as a sort of peer support mechanism and a quick way to access knowledge of a sort of practical nature. I can't give you the exact figures off the top of my head, but there are very few people who were unvaccinated. And if they were unvaccinated, it was because it was pre-vaccine that they got COVID. So their initial infection predated the advent of vaccines here or wherever they were in the world. Is it okay that 5% of people who get COVID, which is a big number because it's infectious, have lived diminished lives for an indefinite period of time, and that's the price that society pays for carrying on? I don't think so. And then, so those are the people, then we say, well, those were, I hate the way we talk about, oh, well, the healthy people who were vaccinated got it. Oh, sorry for them, they got it. But what about the people for whom life was already challenging before, and then they get an infection, and that just compounds inequality, and that seems to have disappeared out the window. So I think the important thing for the people in the Facebook group to get out there is to express the nature of what it feels like to live with it, and to say that it's not okay for people to be making decisions in an information vacuum. People's experiences of seeking help have been not universally negative, but I'm doing the analysis at the moment, and quite often you'll get a really very distressing comment about some interaction with a medical service or medical provider, coupled with a qualifier that says, I know this person themselves is stressed. I know this person has lived through the pandemic. I know they've been at the front line. However, I'm the patient presenting, and this is the response I've got. So it's quite difficult, because tired, sick people are seeking help from tired, sick people in a system in which there is very limited knowledge. So, of course, very few people are going to feel well listened to, well cared for, and well supported, because time and energy is in short supply. I think there's a lack of knowledge for individuals at the public to make decisions about going out, and a lack of being able to control the variables. So I can put my mask on, I can choose where I'm going, but I can't do anything about what anyone else does. And that's an uncontrollable variable for me as an individual, if we're looking at this as an individual person thing. When you start going into the healthcare system, you are somebody who is a confounding variable who nobody knows what to do with. So the medical system set up to cope with highly specialists who deal in parts, not wholes. So they're very few. It feels like there are very few people who care for the whole person and all the systems that are connected. So to start with, I had lots of Well, no, the reason, okay, so they run you go to the doctor and they say, okay, we have to exclude all these things, so go and have all these tests done. So you go and have all the tests done, and of the enormous amount of blood tests that were done on me initially, the only thing that came back within some kind of region of caution was that I had raised cholesterol. So all anyone could focus on in the beginning was my raised cholesterol, but I couldn't breathe, I couldn't stand up, I couldn't, do most things. And my cholesterol was not worrying me, and it wasn't what I was there for. But I was sent through 3 different cardiologists. Each one of them gave me a perfect sticker. One even stood up and congratulated me and said, I don't often send people from my rooms with a clean bill of health, expecting never to see them again. And so I did 3 rounds of cardiologists and got nowhere. And that's time and money and resources. And those cardiologists could be helping people with real needs, let alone not us spending all the money on them. And they seem incapable of acting outside of their wheelhouse. It's like I have inappropriate sinus tachycardia, and that shows up in event-based incidences. I've done 24-hour ambulatory blood pressure monitoring. I've done 2 cardiac echoes, 1 cardiac stress echo. I've done a CTCA. I've done a 1-month event monitor. Those are the cardiac things. I don't know if there's anything else, but in all of that, they can find, and during those things, you're supposed to record events. So you diligently record your events, saying what you were doing, so they can say, well, hanging up a load of washing or brushing your teeth ought not to raise your heart rate to 148, and blow drying your hair ought not to raise your heart rate to 181. And I write the information diligently into the app for my heart bug or whatever it is that's measuring something. And they come back and they say, no, it's all normal. There's nothing, because normal is the event didn't last for longer than X number of seconds, or it didn't happen here, there, or I don't know what normal is. But to be told that blow drying your hair with a heart rate of 181 beats a minute is normal, and to be expected to be able to function just on activities of daily living. We're not even talking about leaving the house. So whether that's loading the washing machine, before I was put on beta blockers, I couldn't load a washing machine. The act of bending and sticking the washing in the washing machine would have me passing out. So I got all these wonderful clean bills of health from all these cardiologists, but I couldn't function. So I had this hideously reduced capacity for function, and I kept being told, you're all good to go. I probably won't need to see you again, or cheers. And so then you go, well, I don't need to see any more cardiologists. And they wouldn't even prescribe beta blockers or consider. A lot of patients with long COVID have something called orthostatic intolerance, which you would know as a medical person, but it's just not something. People go, well, why do you want a diagnosis? It's not going to help you. Nobody knows how to diagnose it, or nobody's willing to diagnose it. Once you figure out that you definitely have orthostatic intolerance, you might have postural orthostatic tachycardia syndrome, but nobody wants to diagnose it. Then they say, well, why do you want a diagnosis? Well, I want a diagnosis because I need to be able to manage my symptoms. And there's a lot of simple things that I can do that are onerous, but simple, and I can do them. But if I don't have this, I don't want to be doing them. So could we please rule it in or out, and then I'll deal with it? And I still don't have a diagnosis of postural orthostatic tachycardia syndrome, although I have enough data to kill an elephant on it. And it was the respiratory physician who put me on beta blockers, because he took my hand and put a pulse oximeter on it when I was sitting in his room. And he said, it's not normal for your heart to be doing 138 just sitting here talking to me. And I'm on the tiniest dose of a beta blocker. And it's quite confronting to be able to tell you that was a game changer. It turned my tiny, miserable life into a tiny, bearable life. And 3 cardiologists wouldn't prescribe or even think about prescribing a quarter of a beta blocker twice a day. It's now created other problems. I've now got very low blood pressure, which is something we'll need to deal with. But there are simple things that people can do that make an extraordinary difference to my level of functionality. And it took 7 months before somebody prescribed me a quarter of a beta blocker twice a day. That I don't want someone else to live 7 months like I did just to get a quarter of a beta blocker twice a day. That's just wrong. So yeah, and then there's other things like the low cortisol. The people living with long COVID are doing a lot of reading, and I don't want to be the expert in long COVID. I don't want to be reading journal articles on long COVID, but I end up doing that because in the absence of help from humans, you go looking for help from journal articles, and there is, we all know in the groups what we're dealing with from the wet end. We just don't know how to fix it. I'm having great difficulty with cortisol levels. But again, how to unpick that? I can't function without cortisone, prednisone. So, and I went into, I was in a very bad state when somebody picked that up. Again, it was the respiratory physician who picked it up. I still haven't had my initial consultation at the long COVID clinic. I am scheduled to be there on the 5th of December, and I'm looking forward to going. But any help I've had has been out of sheer persistence on my part and going private to get access to specialists who can help you.
And presumably that's the experience of many of the members of the Facebook group, that sort of thing. Yeah.
In August, so what happens is when someone gets you get a text saying your first appointment at the clinic will be on whatever date. In about August, people were getting text messages to say their first appointment was in February or March 2023. So we know, so it's like a big celebration when someone gets a text saying your appointment. So we know what the time frame from how long ago those applications were put in to when the people are getting offered an appointment to when the actual appointment is. And it's very, very long. I know of somebody who went to an appointment, an October appointment at one of the clinics this recently, and they got turned away because they had misread the email. It was October 2023, not October 2022. And they'd pitched up for their appointment a year too early. So that's what's happening out there. And equally, I know from the St. Vincent's Clinic, they only, I don't know the exact details, but it's only 2 days a week and a couple of people. It's not a lot of people. They need resources and funding. They've got a model that works. Why isn't funding being given to the people who are doing good work and allowing them to do more good work to reach more people? Instead, they limp along and everybody goes, oh, it doesn't matter, Sydney's got the St. Vincent's Clinic. Well, Sydney's St. Vincent's Clinic is doing really well for a very few very sick people, and that's a good thing. But there's a lot of people out there that are waiting hugely long time to get help or being referred to as out of area. So there's a lot of that's happening. So people who've applied, they're being told, no, you're out of area, you must go and see whatever, but there's nothing in that area. They must just go and see their closest hospital or something.
What states, what are the states where there are no clinics?
They fly to Sydney and see the specialists here privately, if they've got the money. If not, they do the best to make their own adventure, cobble their own treatment pathways themselves. Mm-hmm. So there's a couple of funny things that happen is when you get long COVID, it takes you a while to realize that nobody's got any answers. So you have to kind of there's that beginning bit where everybody's frantic, like someone's keeping the answer from me. Like, I know there's an answer there. They're just keeping it from me. And then you hit your head against the wall again and again. And you realize that no one's got really good answers for you. And there aren't good answers. So then you kind of go, well, then you make the switch from getting better to treating your symptoms. And then you go, well, I need to understand my symptoms. So then you go and find somebody who can help you understand your symptoms, if you're lucky. If not, you stay at home. You read journal articles and you talk to people on the Facebook group. And then there's a lot of just lifestyle adjustments or simple things, like a lot of people have have worked with antihistamines to reduce certain symptoms, but it's all hit and miss. Some of the people that have been very good, Emerge, there's a group called Emerge who are, I don't know if they're officially registered as a charity or an organization or what they're, but they are support for people with myalgic encephalomyelitis or chronic fatigue syndrome. And they have been very generous in helping and supporting people with long COVID to learn how to pace, so how to manage your activities of daily living within an energy envelope. So groups like that have been run off their feet.
I saw a news item on this lunchtime ABC News, an interview with the head of Emerge Australia, and she was complaining about the fact that there was no money in the federal budget for them to be able to maintain the support work that they're providing for long COVID.
That's a crime, because they have been one group that has actually supported long COVID patients throughout Australia. They are very generous. The way they synthesize and disseminate information for people with limited energy is extraordinary. The access that they've given all of us to a 20-minute consultation with a nurse has been unquestioning. The fact that I think that's the thing that we kind of have to, if this is going to be an agile response to something that's unknown, surely one of the clever ways to go about it is to see who's doing support well and helping them to support more people. Why do we have to go and have a new whole invention of something? Why can't we find the people who are doing good work and finance them to do more good work? No, we must go and have a whole get together and figure out what we will do. People are sitting out there. Well, they're not. They're lying in bed or on the couch. They're not doing anything. They are incapable of, when I am stressed, I cannot stand to brush my teeth. I cannot wait for the kettle to boil. I cannot load a washing machine. I can't cook a meal. So we haven't got time for people to go and dream up a solution when there's people like Emerge or the St. Vincent's Clinic. They're doing good work and they are helping people. Why can't we help them help more people? Why do we have to have a new special something or other? I mean, if we need something new, that's great down the track. But right now, it's too long. 7 months of living like this is too long. And there are people who've been living like this for 2.5 years.
And as you said at the beginning, for a casual worker, for a low-paid worker,
they've lost their job. They've lost their income. If they're paying a mortgage, they've lost their house. It's crippling. It is impossible. And one thing that I find quite distressing is that amongst the Facebook group people, there are a lot of teachers, so classroom teachers and nursing staff, and the difficulty those people are having in getting support, ongoing support for long periods of time is really confronting. So these are the people that are out there, and because of their jobs, they're at risk. And then when they get sick, they are not. And there's a spectrum. So there are some people who have been well supported. So it's not all bad, but the vast majority of people who, especially the casuals, who get stuck in the space, there is no backup for them. So you're so exhausted you can't stand up to brush your teeth, but you must now go and fight for benefits so that you can keep your house or feed your children. And there are a lot of, because of because more women in the age bracket of whatever we're talking about, whether we're talking 35, 40 to 55, get it? Then that people who are not only economically active, but they're raising small children. And there's a lot of single women who have not got permanent employment who are dealing with this, and the long-term health outcomes for those people who keep pushing themselves. I'm going to say crippling, and that's the horrible thing, is it is crippling. They end up in wheelchairs and nobody knows that. So they're so confronted and so ashamed that this unknown thing has put them in a wheelchair, and they're not really crippled. They can get up sometimes. They just can't be up all the time, that's not okay. I think for me, the biggest feeling is that it's a squandered opportunity, because we had a degree of safety. I want to use that word, and we should start talking about it like that. We had an enviable degree of safety, which we have well and truly squandered for no good return. I just think that's inexcusable, that you can think so little of risk to human life, that you can have a relative advantage and for no good return you can squander that. And to be on the side of the people for whom that, the things that's not just for those 5% of us that are sick now, the risks to everybody are compounding and are huge. So you don't have to have long COVID to end up with adverse health outcomes in the first year, or we don't know how long, in 5 years or in 10 years and 12 years. But there is research to explain carefully that even if you don't get long COVID, you've got a much higher risk of heart attack, stroke, diabetes. And this is happening, and people are seeing it, and people, the fact that I have a pulmonary embolism and it's related to long COVID is one thing, but I've got long COVID, so people can dismiss that. That's when you get long COVID, the first thing people do is they try to understand what's different about you, that you got it. Why were you the weak link that ended up with long COVID? Because they want to understand how it is that they're not going to get it, and that they can go out there with no mitigation strategies time after time after time and get it, and it's just the flu, and they're going to be all right. They want to believe that, but public health messaging ought to be disabusing them of the fact that it is not the flu, and the flu does not do this to you. The flu does not impact every body system. It does not leave you vulnerable to all sorts of really unpleasant things. It's not nothing, and public health messaging ought to take that into account. And now that we've just scrapped everything, it helps everybody if we just don't talk about it, and if we don't bring it up, and if the long COVID people who are just the 5%, if they could just stand to the side and stay at home on the couch, that would, we feel, because it's relapsing and remitting, and because nobody understands it, and because there aren't any fixes, and because we're all so tired, there's a sense of shame in actually how functionally incapacitated you are. So you don't go out there, you aren't insisting that you have a wheelchair to get you from A to B, and you aren't saying, you're trying, you really want to be back to normal, but you're not. So it helps people just paper over the cracks. And that's short of us all going out and taking our couches and going and sitting somewhere. I'm not sure how we make people understand it. And that's, I'm being facetious there, but there's an enormous amount of hidden pain that's not being recognized. And I've lost my train of thought. So you spend any length of time with me and you realize she loses a train of thought.
Yeah.
I'm tired of apologizing. I'm an academic. I get paid to think for a living. I can't hold a line of thought for an hour. That's not fun way to live. I think emergency departments must be really tired of seeing long COVID patients, because we're not going to die today, but we're pretty miserable and we're terrified that pain that we feel will kill us today. So emergency departments must be just swamped with people like me.
If you could provide a short list of what should be done, what would be the 4 or 5, whatever, what would be the essential items that you think need to be done?
Mandatory isolation. So people who are sick should not be in circulation. When you go out in public spaces, you ought to be masked. And if notification of an infection is no longer required, that clever thing they do with the sewage, where they can tell by a postcode what the incidence is. I want to have a dashboard that tells me by postcode I don't want to just know whether it's going up or going down. I want to know in relation to when Omicron was at its peak, this postcode is now off the charts. So if I have to make a personal choice, I want to be able to see the sewage, the whatever you call it, and they can do that. They're doing it already because they are reporting weekly and they just say up or down. If they were a bit more transparent with that data, those of us who want to be responsible can be responsible. We just can't get our hands on that data yet. So yes, people who are sick should stay at home. All people in public spaces, if you can't, so be distanced or to be masked. It's not fun being masked. It's horrible teaching in a mask, but I'd rather not be getting it or passing it on. So those things. And so notification of who's got it and tracking the money and where that's being spent, and us being able to tell where contact tracing through the search. And that's not too hard. That's my practical list. My not practical list is clean air for everybody tomorrow. Like, we can do that. We just have to have the money we have to have the will to do that. Support for people who are stuck at home. So people who've lost their jobs, people who need to rest. Some of us need to rest for 12 months, or hopefully when the research gets better, it won't be 12 months or 2 years. But if some person has 3 small children and a mortgage and they're the sole income earner, they shouldn't be on the street. So they should be taken care of. And proper funding for people doing good work. So the people that are making a difference in the communities, they ought to be resourced. Till the 30th of September, we had a chance to do things differently, and we had an advantage, and we have squandered it.
And the social consequences, the consequences for public health?
We're not going to even begin to understand them for another couple of years, and then we will be drowning.
We're in an information war, and we really have to step up the fight here. And what this has demonstrated to us is that there's got to be a movement from below. It's not going to come from the powers that be. They are too bought and paid for, to put it in colloquial terms. Either party, they're just proceeding on the basis of the demands of big business. So it's got to come as part of an independent movement of ordinary people that's going to force change here. And that's the basis on which we're, taking forward this work.
Thank you. And that's the other thing, is that one of the reasons that's allowed to happen is that those of us with long COVID are depleted. So although it's great where people who are not depleted in energy and resources who are actually taking it, because whilst it might be invisible, it's very debilitating. So it doesn't leave you with extra energy to do some sort of coordinated anything. Yeah. Getting yourself organized in the morning is about as coordinated as one can get. But no, so thank you. Yeah, it's really important. And I'm sure there's lots of things I didn't say.
Pippa,
thank you for your time, and it was nice to meet you.
Thank you for your time. It's very difficult for you, and we really do appreciate it.